Drugs like Ozempic and Wegovy changed the conversation around weight loss almost overnight. They work, that much is very clear. But they come with real trade-offs in cost, side effects, and never-ending treatment cycles. These trade-offs represent a market opportunity, and right now, the pharmaceutical industry is pouring resources into weight loss research. So what comes next? In this video, we'll take a closer look at the next generation of weight loss drugs. We'll talk about what problems they're trying to solve, how they compare with what's already out there, and when we might expect to see them. Let's break it down. For decades, the obesity drug pipeline was a graveyard. The treatments that were safe barely worked, and the treatments that worked were barely safe. So when the chemical behind Ozempic, which is called semaglutide, came along, hardly anyone really expected it to change much in the industry. It was designed to help people with type 2 diabetes, but then doctors started noticing something unexpected. In clinical trials, people on semaglutide were losing up to 15% of their body weight. And this wasn't just for a few weeks, they were keeping it off for over a year. That type of weight loss had never really happened before, not at this scale or with this level of safety. It turns out semaglutide mimics a natural hormone in your gut, GLP-1. And this hormone signals to your brain when you're full. So in 2021, the FDA approved a high dose of semaglutide for weight loss under the name Wegovy. Ozempic and Wegovy went viral. Doctors were prescribing them in record numbers, influencers couldn't stop talking about them, and right as this hype was peaking, an even more promising solution stepped in: tirzepatide. Tirzepatide didn't just mimic one gut hormone, it mimicked two, GLP-1 and GIP, and it led to even more weight loss in clinical studies. So in 2023, the FDA approved tirzepatide for obesity treatments under the name ZepBound. These GLP-1 drugs were stirring up a storm online, and they were some of the most talked about medications in the world. But everyone wanted to know, have we finally found the miracle weight loss cure? But unfortunately, the deeper these drugs made it into real world, the more complicated the story became. These drugs actually had some problems. First of all, a lot of people took these drugs and didn't see any major results at all. Not everyone loses 15 to 20% of their weight. Some people hit a wall early, and some people build a weight back even while they're still on the drug. And that brings up the question, what happens when you stop taking these drugs? Well, unfortunately, it's not a permanent cure. These drugs are more of a recurring subscription. A year after stopping semaglutide, most people regain 2/3 of their weight that they lost. And this isn't because of a lack of discipline. You see, after you come off this drug, your body screams at you, telling you it wants to return to its natural weight. Semaglutide doesn't reset your body's natural weight baseline. And tirzepatide is similar. When you stop taking these, your body thinks that it's starving and starts to try and fight back. Your cravings return and you start gaining back the weight again. Another setback is these drugs are also expensive. They can cost, in some cases, more than $1,000 a month. And unless you have type 2 diabetes, most insurance plans won't cover them. And when coverage exists, it's often tangled in red tape. Another challenge with these drugs is tolerating them, tolerating the side effects. Many patients experience nausea, especially in the first weeks, in the early weeks, and others deal with digestive issues and acid reflux and exhaustion. And then, of course, the side effect that probably gets the most amount of attention is the muscle loss. In some trials, up to 1/3 of the total weight loss is lean mass. And now doctors are raising tough questions. If skeletal muscle is shrinking, could cardiac muscle in your heart, be shrinking too? We don't know yet. So doctors are telling people to lift weight and to eat protein alongside the treatment, not just to stay strong, to protect their hearts. So this current generation of weight loss drugs, it proved that this pathway can work. But now there's a race on to develop new drugs that will work even better. Look, the question isn't whether we can help people lose weight. That question has been answered. It seems like yes, we can. The question is, can we do it with fewer side effects, fewer patient dropouts, better access, and maybe, just maybe, not endless treatments? And the pharmaceutical industry is racing to capture this value. Some people just can't tolerate full doses of GLP-1s. The nausea hits too hard, the fatigue drains them down. So researchers have started asking, what if you don't have to crank the dose up so high to get the same effect? And that's a question Novo Nordisk is especially trying to answer. CagriSema is a combo drug. It combines semaglutide with a second hormone called amylin. Their idea here is to let two different hormones share the load. Both of these hormones suppress the appetite, but in slightly different ways. If this works, patients would be able to lose just as much weight, but with much lower GLP-1 doses, and so much lower side effects. This drug is already in phase 3 of clinical trials, and it could come as early as 2026. Another problem with all of those weight loss treatments that I've talked about already is they come in an injection form. And let's be honest, weekly injections kind of suck. They suck for the patient, for the end user, but they also suck from a supply chain perspective. So there's two problems. You need refrigeration, and you need a patient who's willing to stick themselves every 7 days, possibly for life. That's a huge barrier to scale, especially from a supply chain perspective when you're outside the US. And that's where Eli Lilly and orforglipron is getting so much attention. It's not a shot, it's a pill. It's a once daily oral GLP-1 receptor agonist. So no needles, no cold supply chain, you just take it with water. In early trials, it delivers about 14 to 15% weight loss, and this is on par with Wegovy but without the injection. If it keeps performing well and with few side effects, it should be on the market by 2026, and it will open the door for a lot more patients worldwide to get started. But then there are the patients that do actually tolerate GLP-1s and they don't mind the shots. They can still run into another problem. They lost weight, sure, maybe 10-15%, and that's great, but then the weight loss stops. Their body adjusts or their appetite kind of crept back in. They need something stronger. And that's where Retatrutide comes in. This drug doesn't just target GLP-1. It targets 3 hormones at once: GLP-1, GIP, and glucagon. The early results for this one are stunning. In some trials, patients lost up to 24% of their body weight in under a year. That's basically on par with bariatric surgery, but it's just a shot. There's no invasive surgery, there's no recovery time. Retatrutide is still in phase 3, but if it holds up, it could be approved by late 2026 or 27, and it would reset the upper limit on how much weight you can actually shed using these types of medications. But all of those treatments are aimed at reducing side effects or changing the delivery mechanism to a pill or increasing the impact. And that's great, don't get me wrong. But there's still a bigger issue. None of that fixes what's happening when people stop taking the drug, because most of the people do regain the weight. And that's where a next frontier is starting to emerge. Not just better drugs, but ideas for how to hold on to the progress after the drug cycle ends. One of the more unusual solutions is called Revita. It's not a pill, it's not even a medication, but it's a procedure. It's a kind of metabolic reset. It resurfaces the lining of the upper intestine to retrain how the gut sends signals to the brain and the pancreas. The interesting thing about this one is early studies suggest that Revita might actually help people maintain their weight loss after they've stopped GLP-1s. And the FDA has already given it breakthrough device status, so it could become the first real tool for tackling post-drug relapse. But it's still early days, and that's an invasive procedure. So then there's LX9851. This is an experimental drug, and it targets fat metabolism. It's being tested as a potential companion to semaglutide, not to replace it, but to make the effects more durable, and maybe to soften the landing if someone comes off treatment. It's still early, but this represents a shift in mindset. We're not just trying to help people lose weight anymore, we're trying to help them keep it off. And what ties all of this together, from combo hormones to pills to triple agonists to gut resurfacing, is the idea that this time we're building that second wave with eyes open. We know what the first wave could and couldn't do, and now we're designing around it. This next generation of weight loss treatments, it's not just stronger, it's smarter. And if it delivers, it could finally turn these short-term victories into something that actually lasts. It turns weight loss from a chronic management model into something that's more dynamic. A treatment arc with a beginning, a middle, and an end. And if we do this right, these drugs won't just shrink bodies, they'll shrink treatment timelines too. And that's where the real disruption is. Not just helping people lose weight, but helping them move on.